very much. I am Sharifa, and today I'll be discussing about cardiovascular risk stratification for patients with type 2 diabetes. And so these are the learning objectives for today. So understanding the epidemiological burden of cardiovascular disease in patients with type 2 diabetes. And then we learn how to apply evidence-based risk stratification tools in primary care. And after that, after we apply the tools, we can develop personalized management strategies based on these risk profiles so that we can initiate early intervention based on clinical guidelines. So the burden of cardiovascular disease and diabetes is actually a bidirectional relationship. So globally, type 2 diabetes affects over 460 million adults, and cardiovascular disease is the leading cause of mortality in this population. In Southeast Asia, at least 215 million people have diabetes, which is projected to rise as well. And diabetes is an independent risk factor for cardiovascular disease. And patients with diabetes, they face a 2 to 4-fold increase in cardiovascular events compared to patients without diabetes. And this is important to know later on as we go through the slides. And cardiovascular disease is also a risk factor for patients to have that type 2 diabetes. And those with established coronary artery disease, they have a 1.5 to 2-fold increase of getting diabetes compared to those without any cardiovascular disease. And this bidirectional relationship can be mediated through shared pathophysiological mechanisms, including chronic inflammation, oxidative stress, insulin resistance as well. So this demonstrates that there is an increased risk for type 2 diabetes to get cardiovascular disease and vice versa. So there's this bidirectional relationship. The clinical implications, why is it important to understand this relationship? So these are the clinical implications for risk assessment. Patients with diabetes, they require more aggressive risk assessment regardless of traditional risk factors. And this includes things like obesity, sedentary lifestyle, family history of diabetes, things like that. So as long as you have diabetes, it requires more aggressive cardiovascular risk assessment to reduce your long-term risk of getting cardiovascular disease in future. And you can see here from the ADA guidelines in 2025, there are 4 planets to reduce diabetes complication. So it's not just about glycemic management, sugar control, it's also about blood pressure control, cholesterol control, and also using agents that have cardiovascular and kidney protective benefits. And patients who have cardiovascular disease, they should also be screened at least yearly for diabetes and pre-diabetes. And risk assessment tools must account for this interconnected bidirectional relationship. And treatment strategies also should address both conditions simultaneously rather than in isolation. So these are some guidelines according to the American Diabetes Association, European Society of Cardiology, and also American Heart Association. So the common thing about these guidelines, even though they can be a little bit different in the nitty-gritty details, the common thing is that they consider diabetes as a high-risk condition, especially if you have it for more than 10 years already. So then you have to automatically just class these patients, categorize them as high-risk category, and then treat them accordingly. And the thing also is to have mandatory screening for diabetic nephropathy. So you check the EGFR, you check the albumin-creatinine ratio, and you check for the eyes and the feet for that patients with diabetes at least annually, because these are all cardiovascular risk modifiers. But despite established guidelines, significant gaps still exist between recommended cardiovascular risk assessments and the implementation in primary care. Studies indicate that up to 40% of diabetes patients receive suboptimal cardiovascular risk evaluation. This leads to missed opportunities for preventive intervention. So I'll share with you a few risk classification tools. We should localize it in one's context because there are many out there, well, a few out there, but it has to be very individualized to the population because they use population health data. So one population may differ from another population. So the first one is this ASCVD Risk Estimator Plus. And this is for primary risk scoring. So for patients who've never had any cardiovascular disease before, asymptomatic. And this estimates your 10-year risk of getting a heart attack or stroke for asymptomatic men and women. And this is usually validated for the general US population. Now we go on to the Q risk 3, which was most updated in 2018. And this one is also a primary risk scoring to assess one's risk of developing heart attack or stroke over the next 10 years. And this is for the UK population. So I actually tried to use this in one of my patients in Singapore, and they overestimated his risk by quite a lot. Actually, they classed him as intermediate risk, which we'll go on later to find out how many percent that is. So then I had to tweak it according to the local guidelines and also the Singapore risk calculation, which is this thing right here. So we have our own risk calculator in Singapore, and as you can see, it's quite a lot of questions, but they take into account things like kidney disease, familial hypercholesterolemia as well, the genetic condition, and they also take into account any history of cardiovascular disease and diabetes. So the risk calculator, once you key in all the figures already, then it comes up with a scoring system, whether you're low, intermediate, or high risk. And generally, low risk will mean that it's below 5% of getting any kind of adverse cardiovascular outcomes within the next 10 years. Intermediate risk will be between 5 to 20%, and high risk will be more than 20%, or they already have established cardiovascular disease. So in this case, ASCVD actually doesn't just refer to a heart attack or a stroke. It can even mean peripheral artery disease. It can even mean aortic atherosclerotic disease as well. So that's important to know. It's not just a heart attack or a stroke. Okay, so this is a summary of the risk management for patients with type 2 diabetes. So we stratify according to the risk calculators that we have, and depending on your local population, you will use your local risk stratification tools. Once we do that, we may perform further risk assessment if it's considered to be maybe intermediate or high risk. We perform further assessment using an ECG, an ABPI, ankle brachial index, for especially if we suspect peripheral artery disease, or we can also do a coronary calcium scoring as well to further risk stratify these patients. And then once we have done that with the results, then we manage accordingly in those with high risk or those who already have cardiovascular disease. So we can use the new kids on the block, the GLP agonists, or we can use the SGLT2 inhibitors as well, with or without metformin. And we will go into more detail about these two medications later. So the GLP-1. So the GLP-1 receptor agonist, this is a meta-analysis composing of 8 trials and over 60,000 patients. And these investigators were encouraged to manage participants according to their local guidelines. And everybody in these trials, the median age is about 60 to 66 years old, which is about the age, to be very careful to, not get cardiovascular disease. So the 3-point major adverse cardiovascular event actually includes cardiovascular death, non-fatal MI, and also non-fatal stroke. And they found that GLP agonists actually reduce all-cause mortality by 12%, hospital admission for heart failure by 11%, and the kidney outcomes, means kidney progression, by 21%. And there is no increased risk of severe hypoglycemia, retinopathy, or even pancreatic adverse events. So the cardioprotective effects of GLP-1 agonists cannot be disputed, and this represents an important treatment opportunity to reduce morbidity and mortality in patients with type 2 diabetes. SGLT2 inhibitors, on the other hand, so they also looked, meta-analysis composes 6 trials, about 4,900 patients, just shy of 5,000 patients, and about 81.6% of them, they actually have MACE outcomes. So MACE outcomes in this case will be MI, myocardial infarction, stroke, or cardiovascular death. And they found that overall, SGLT2 inhibitors significantly reduce the risk for MACE, but that's about 0.9. So the effect is quite modest, actually. The overall pool estimate is modest, but it shows there is still some benefit in having SGLT2 inhibitors for our patients. And this is usually shown in the SGLT2 inhibitors of empagliflozin and canagliflozin. So we have to be careful. There are certain types of SGLT2 inhibitors, not all, that actually can reduce your risk of MACE. If we look more closely into hospitalization for heart failure and kidney-related outcomes or kidney progression, you can see that the overall pool estimate is actually a lot more to the left of the line. So that means the hazard ratio is a lot less. So the risk reduction is actually a lot more and very consistent across all the trials, and they show that it's actually very favorable, specifically for hospitalization for heart failure and for reducing kidney progression. So this is actually really good for our patients, not just to lower glucose control, but also to protect in terms of long-term risk management. So being a lifestyle medicine physician, it would be remiss of me if I didn't mention anything about lifestyle medicine. So as you can see from my first few slides, the pillars of the how to reduce diabetes complications, at the bottom there, if you notice on the steps, the foundation is still lifestyle management. So that is something that we should not forget. And in lifestyle medicine, we have 6 pillars, which is nutrition, and we emphasize a predominantly whole, very minimally processed food diet, adequate physical activity. So it's not just about exercising, but as long as you get up and you move around, be regularly physical, that is the idea. Restorative sleep is important as well, because studies we all know, we have shown that a lack of sleep increases our risk of chronic inflammation and long-term risk as well of metabolic syndrome. Reducing stress, relaxing, having a positive mental attitude also helps. And then the 5th pillar is positive social connections. We build relationships, we build networks that can improve our physical and mental health. And the last pillar will actually be avoiding risky substances such as alcohol, smoking, and also drug consumption. So this is according to the ADA guidelines from 2025, very updated. So this shows the lipid management for primary prevention of CVD in patients with diabetes, in addition to healthy behavior modification as well. So in below 40, we are advised to consider statins if there are additional risk factors such as high blood pressure, smoking, obesity, and things like that. For those between 40 to 75 years old, we're encouraged to use moderate intensity statins. And for those with more than one CVD risk factor, we're encouraged to use high intensity statin. So that includes atorvastatin or rosuvastatin even, to achieve the target of below 1.8. We may or may not want to add ezetimibe or the PCSK9 inhibitors, just so we can achieve this target of 1.8, which is actually really low, and something that I get a lot of backlash from my patients because this is very low for them. They feel like it's very unreasonable, but it actually has been shown to have benefits. So I think that's something that we should encourage our patients to try to achieve towards. And those who are much older, above 75 years old, we are encouraged to continue this therapy or consider a moderate intensity statin. Okay, and then the ADA guidelines also mention about secondary prevention of cardiovascular disease. So once somebody already has established cardiovascular disease, how do we prevent? The target for cholesterol management actually goes down even lower to 1.4, or we have to reduce the LDL by 50%. And this is done by using lifestyle management and also high intensity statins, like I mentioned earlier. And we may or may not add ezetimibe or the PCSK9 inhibitors as well to achieve this target. So in summary, diabetes control centers around long-term risk management. So it's not just about lowering sugar levels, HbA1c. There is this bidirectional relationship that we need to appreciate and understand between cardiovascular disease and diabetes, because as the burden of cardiovascular disease grows, effective risk stratification is not just beneficial, but it's very essential for optimal patient outcomes as well. And there are many risk stratification tools that we can use, but it's important to localize to one's context. So novel agents as a cornerstone of diabetes and CVD risk management. So these would include your GLP-1 agonists and also the SGLT2 inhibitors, depending on the outcomes that we want to achieve. whether it's kidney progression, hospitalization from heart failure, and things like that. So the key takeaway here is to risk stratify our diabetes patients. Always use, as much as possible, we try to use the risk stratification tools when we diagnose somebody with diabetes or when we follow up our patients with diabetes. So with that, I share with you my references, and thank you very much for your time.
It is truly an honor to join this webinar. This is available opportunity to discuss the importance of early screening and prevention of chronic kidney disease in patients with type 2 diabetes in primary care. It is a crucial topic, and an early intervention can make a significant difference in long-term outcome for our patients. My presentations will cover three main objectives. First one, to highlight the importance of early screening in newly diagnosed patients with type 2 diabetes. Second, to provide updates on current guidelines for the management of diabetes kidney disease in primary care. And the last one is very important and interesting to illustrate this concept through real clinical case from our practice. The prevalence of diabetes in Vietnam is increasing rapidly. This growing trend presents a significant public health challenge. It may lead to serious long-term consequences for our healthcare system and population. On the screen, you see there's a number of people with diabetes. It's rising every day. Today, about 537 million people worldwide are living with diabetes. However, less than 50% of patients achieve their treatment target, defined as hemoglobin A1C below 7%. And in addition to diabetes, many patients have society's risk factors such as obesity, hypertension, hypercholesterolemia, and cardiovascular disease. In particular, chronic kidney disease is a major concern, affecting about 50% of people with diabetes. Vietnam has a high rate of diabetes compared to other countries in the Asia-Pacific region and globally. From 2017 to 2045, estimated the prevalence is projected to increase by 78.5%, meaning the number of people with diabetes in 2045 will be nearly double that of 2017. Unfortunately, only about 31% of cases are diagnosed, leaving nearly 70% undiagnosed. Among those, only 34% suffer cardiovascular complications and 24% have kidney complications. And last one, information, only 28.9% of diagnosed patients got treatment in primary care. The Revin Sikari study is an observational work, provides estimated for several countries. We see that the prevalence of undiagnosed stage 3 CKD, even in developed countries such as France, UK, USA, and Japan, is higher than that of diagnosed stage 3 CKD. CKD is global and national healthcare burden in Vietnam. Worldwide, 850 million people have chronic kidney disease. According to statistics from Ministry of Health in Vietnam, approximately 9,000 new cases occur annually, but only 10% are diagnosed and treated. High-risk CKD is associated with increased risk of cardiovascular events and deaths. As shown on the slide, patients with reduced kidney function can have up to 5-fold higher risk compared to those with normal eGFR. Early screening for CKD in patients at risk in primary care setting, we often identify individuals at risk for CKD. There are many contributing risk factors. For example, hypertension, diabetes, cardiovascular disease. In this presentation, I would like to focus on diabetes. According to the recommendation of Ministry of Health, the ADA and Cardigo, we commonly use to test eGFR, estimating glomerular filtration rate, and urine albumin to creatinine ratio to assess kidney function for the early detection of chronic kidney disease. The diagnosis of CKD is confirmed by eGFR of less than 60 milliliter per min or an urine albumin to creatinine ratio greater than 30 milligram per gram, persisting for more 3 months. Let's briefly talk about UACR, which play a crucial role in the early detection of chronic kidney disease. Even when eGFR levels are within the normal range, the presence of albumin in urine can indicate underlying kidney damage. In fact, studies show that around 34% of individuals with normal eGFR might still have underlying kidney disease. Like screening CKD by using eGFR and URCA or on diabetes patients, according to Cardigo 2012 guidelines, the frequency of testing for chronic kidney disease depends on the UICR and eGFR. On the screen, you can see the numbers 1, 2, 3, 4, and more. It depends on the what stage of kidney disease and how many albuminuria in albuminuria. Even when the eGFR are normal, the presence of albuminuria greater than 30 milligram per gram is still sufficient for diagnosis of CKD. Similar to the recommendation of ADA and Cardigo, the Vietnamese Ministry of Health also recommends that on patients with type 2 diabetes should undergo early screening for kidney function using estimated glomerular filtration, eGFR, and urine albumin to creatinine ratio. You can see on the screen. The mortality rate is proportional to age and UICR level. On the screen, you see all the populations have higher mortality rates, especially when the UICR levels are elevated. This means that risk of mortality depends not only on eGFR levels, but also on UICR levels. This again to confirm there's albuminuria is very big information for our practitioner. Update treatment of diabetes chronic kidney disease. We can see, look at this slides. I summarize the guidelines from 2017 to 2025. We can see that treatment goals have evolved over years from 2017 to 2025. In 2017, the focus was on controlling blood glucose levels. However, today, the approach has shifted. We no longer focus solely on glucose control, but also aim to avoid hypoglycemia and to prevent cardiovascular and kidney complications and weight loss. This means that treatment is no longer the same as it was in the past. Today, we follow a different approach. We now prefer medications. This not only control blood glucose, but help prevent complications. I want to talk about cardiovascular and kidney complications. We can see that SGLT2 inhibitor listed as a first-line choice for all the patients with type 2 diabetes who have a kidney disease or cardiovascular complications. The second recommended medication is GLP-1 receptor agonist. When SGLT2 inhibitor, GLP-1 receptor agonist, when SGLT2 inhibitor not indicate we can use GLP-1 receptor agonist as the alternative, especially for patients with type 2 diabetes who have a kidney or cardiovascular disease. According to IDA 2025 guidelines, in patients with diabetes and chronic kidney disease, SGLT2 inhibitor recommended as the not only improve glycemic control but also slow the progression of CKD and reduce risk of cardiovascular events. Is a strong recommendation. It is chronic kidney disease recommendation by IDA 2025 and Educatio 2024. Metformin can be used for treatment of diabetes, but its use depends on eGFR level. If the eGFR is below 30 milliliters per minute, metformin is contraindicated. In the case where metformin is contraindicated, GLP-1 receptor agonist can be used as alternative therapy. And Cardiorenal 2024 recommendations, similar to IDA, the Cardiorenal 2024 guideline recommend use of SGLT2 inhibitor on patients with chronic kidney disease. It is a strong recommendation with high evidence. And to earlier initiation of SGLT2 inhibitor delays progression to end-stage kidney disease. To measure study showed that DAPA CKD or MPA kidney demonstrated earlier use SGLT2 inhibitor in patients with diabetes at risk of CKD can delay progression in 7.8 years for MPA kidney, for MPA liplosin and 12 years for the dapagliflozin. But one point is very important. When we refer the patient to the specialist, we should refer patient to specialist. It's a recommendation by Cardiorenal 2024. When the disease progress rapidly without clear cause, and when the patient is in the advanced stage, most patients with chronic kidney disease should be managed by primary care providers or family physicians. This approach helps save time, reduce healthcare costs, and allow for continuous and follow-up. As you know, in our society today, the number of specialists is limited. That's why primary care physicians, who are more accessible and often close to the patient, play a crucial role in security management. Now, it's very, we use on the recommendation from ADA and Cardiorenal to the real practice. And on your screen, you can see just case. The woman, 56 a year, with type 2 diabetes, hypertension, makes regular visits to her family physician. At first glance, the patient has no significance. Only we see the BMI 28.5, a bit higher. According to Asian classification, is considered obesity. In addition, blood pressure was mildly elevated compared to the normal. Our treatment goal for this patient is not to control fasting blood glucose, but also detect early abnormalities like the kidney and heart, and to achieve weight reduction. What follow-up clinical tests should be performed on the regularly basis? But according to recommendation ADA 2025, we say that we have to achieve optimal glycemic control. Second, prevent cardiovascular and renal complication. And first one, minimize risk of hypoglycemia. And last one, to maintain weight loss is our target. How evaluate the patient? Follow the recommendation, medical evaluation. The first one, we should confirm the diagnosis and classify diabetes. Second, to assess glycemic status and previous treatment. To evaluate for diabetes complication, review risk factor, and manage plan, including initial goals of treatment. And last one, develop a plan for continuity care. This is our test we order to do for the patient. You see on the screen the results of tests. Here a little bit we can see fasting glucose not so much high. Hemoglobin A1C 7.1. I think not so high. But one thing I want you to think about is albuminuria. Because
hi, Dr. Tom, can you increase the volume? The voice is so difficult to hear from us. Yeah, thank you.
Thank you. I will slowly. In the test we ordered for the patient, we see that in the urine present of albumin. Yes, for heart detection, we order the echocardiography and ECG. Every test are normal. Only one thing we can see is albuminuria. The patient have diabetes only 3 years ago. Before initiating treatment, we need to assess the patient's risk factor. To estimate the risk factor in Vietnam, we can use score, ESM score 2, score D, or score OP, international scale. But in Vietnam, we use score VN or Caribbean tool, which is accepted by Vietnam Heart Association for use in primary care setting. The Caribbean risk assessment tool will be presented in detail by Professor Ang after my presentation. After we use Caribbean tool for assessment risk factor, we see on the screen the patient have very high cardiovascular risk and kidney risk at the risk of developing kidney disease. The LDL-C cholesterol goal must be less than 1.4 millimole per liter, and systolic blood pressure below 130 millimeter mercury. And what we need to do for the situation, we continue the previous treatment or maybe change. In the previous prescription, we was using metformin dose of 2000 milligram. So in this, we see the patient has albuminuria, and so we have to change a little bit. We switch metformin 2000 to 1000 milligram combined with the SGLT2 inhibitor. In this case, we use to improve adherence, we use combination pill to make it easier to take for the patient. Yeah. The second one, we have access to the risk factor. The statin therapy should be switched to high intensity regimen, because before the patient used atorvastatin 20 milligram, it is a moderate intensity therapy. We have to switch to high intensity therapy using rosuvastatin 20 milligram. After 3 months of optimized treatment, we observe an improvement in all parameters. Here we can see the reduced albuminuria, reduced BMI, and hemoglobin A1C less than before 7.1 and today 6.7%. And if the treatment goal is not achieved after 3 months, we will switch from sulfonylurea to GLP-1 receptor agonist, because today GLP-1 receptor agonists not only reduce the glucose, but it also they reduce the waste. And so my summary, there are 4 points. Early identification of CKD in primary care, you can use eGFR, and urine albumin to creatinine ratio is important, no change. SGLT2 inhibitor, a cornerstone in diabetic kidney disease management, and GLP-1 receptor agonist an option for patients with cardiorenal metabolism. And last one is very important, earlier initiation of SGLT2 inhibitor delays progression to end-stage kidney disease. Thank you for your attention.